Welcome back, class. Let's go ahead and do a review of our last session. During our last session, we conducted a true-false introduction of the chapter. We discussed the history of mental health treatment. We also discussed the reforms to mental health treatment and current forms of therapy, looking at psychotherapy and biomedical therapy. Last time we were able to focus on psychoanalysis and psychodynamic, humanistic, behavioral, and we began the discussion of cognitive therapy styles. We'll pick up there where we left off last class. Cognitive therapies. Practice. Cognitive therapy helps people alter the negative thinking that worsens depression and anxiety. Therapists might suggest other thoughts that the clients could have about their lives, or at least point out when clients jump to conclusions that make them feel worse. Schools of cognitive therapy are Albert Ellis's Rational Emotive Behavior Therapy, challenging irrational beliefs and assumptions; Aaron Beck's Cognitive Therapy for Depression, correcting cognitive distortions; Donald Meichenbaum's Stress Inoculation Training, practicing healthier thinking before facing a stressor, disappointment, or frustration. Aaron Beck's therapy for depression. Aaron Beck helped people see how their depression was worsened by errors in thinking such as catastrophizing, interpreting current events as signs of the worst possible outcome. For example, now that I've made a mistake in my lecture, I failed as a professor. Students can't take me seriously and they can't learn from me. Beck's style of therapy helps clients notice and challenge these errors in thinking. Some cognitive therapy techniques. Below are some general goals and specific strategies used in cognitive therapy. One technique is reveal beliefs. Question your interpretations. Rank thoughts and emotions. Explore your beliefs, faulty assumptions, such as I must be liked by everyone. Rank thoughts and emotions. Gain perspective by ranking your thoughts and emotions from mildly to extremely upsetting. Then you have test beliefs. Examine consequences. Explore difficult situations, assessing possible consequences and challenging faulty reasoning. Decatastrophizing thinking. Work through the actual worst-case consequences of the situation you face. It's often not as bad as imagined. Then determine how to cope with the real situation you face. Change beliefs. Take appropriate responsibility. Challenge total self-blame and negative thinking, noting aspects for which you may be truly responsible as well as aspects that aren't your responsibility. And then resist extremes. Develop new ways of thinking and feeling to replace maladaptive habits. For example, change from thinking I am a total failure to I got a failing grade on that paper and I can make these changes to succeed next time. Cognitive behavioral therapy, or CBT, works to change both cognitions and behaviors that are part of a mental health disorder. Using cognitive behavioral therapy, people with OCD are led to resist the urge to act on their compulsions, as well as to learn to manage obsessional thinking. Family therapy. Having a session with the whole family at home or in the office allows the therapist to work on the family system, that is, the family's patterns of alliances, authority, and communication. A related modality is couples or marital therapy. Group therapy assembles about 6 to 9 people with related needs into a group, facilitated by a therapist to work on therapeutic goals together. The benefits include less cost per person, more interaction, feedback, and support, and clients realize others share their problems and they are not alone. And self-help groups. Self-help groups are led by group members instead of a therapist. They can be much larger than group therapy with less interaction. The focus is more on support rather than on working on goals during a group session. Comparing modern psychotherapies. Psychodynamic, unconscious conflicts from childhood experiences, client-centered, barriers to self-understanding and self-acceptance. Behavior, presumed problem is dysfunctional behaviors. Cognitive, behavior, presumed problem is negative self-defeating thinking. Cognitive behavioral therapy, the presumed problem there is self-harmful thoughts and behaviors, and the presumed problem for group and family therapy, stressful relationships. The therapy aim. In psychodynamic, the aim is to reduce anxiety through self-insight. Client-centered therapy, the aim is to enable growth via unconditional positive regard, genuineness, and empathy. Behavior therapy, the aim is to relearn adaptive behaviors and extinguish problem ones. Cognitive therapy, promote healthier thinking and self-talk. Cognitive behavioral therapy's aim, promote healthier thinking and adaptive behaviors, and the aim of group and family therapy, heal relationships. The techniques employed. With the psychodynamic therapy, techniques for therapy are interpret patients' memories and feelings. For client-centered, listen actively and reflects clients' feelings. For behavior therapy, use classical conditioning via exposure or aversion therapy or operant conditioning like in token economies. Cognitive therapy's technique, train people to dispute negative thoughts and attributions. Cognitive behavioral therapy's technique, train people to counter self-harmful thoughts and to act out their new ways of thinking. And group and family therapy's technique, develop an understanding of family and other social systems, explore roles, and improve communication. Using research to help ensure effective therapy. Using client perceptions, therapist perceptions, regression to the mean, outcomes and symptoms improvement, comparing treatment to no treatment, comparing treatments to each other, matching the treatment to the disorder, consider research along with clinical expertise and client characteristics, considering treatments with less research support, common elements of effective psychotherapy, examining such things as culture, gender, and values, preventing disorders. So how do we know therapy works? Okay. There are different measures of the value and effectiveness of psychotherapy. Whether the client is satisfied, whether the client senses improvement, whether the therapist sees improvement, whether there has been an observable, measured change in initial symptoms. Problems with some measures. If clients perceive an improvement, they're trying to justify time spent on therapy. Or if therapists see an improvement, are they just seeing only their good outcomes? And if research shows good outcomes for most clients, would they have improved anyway? Those are some problems that we have with these measures. So studying treatment outcomes. To track the effectiveness of an intervention, we use a control group not receiving the intervention or even a placebo group. To measure effectiveness, we use objective, observable measures of symptoms rather than relying on client or therapist perceptions. Understanding outcome data. So, if we found that even people in a control group, for example on a waiting list, showed improvement, is therapy a waste of time? So what this shows us is that overall, about 80% of untreated people have poorer outcomes than the average treated person. But we do tend to see that people are more likely to improve overall in time, but they're going to be greatly more likely and more probable that they will be able to improve if they're seeking therapy, as well as a lot less likely for the problem that they're experiencing to occur again. So the benefits of therapy are there in the data. Now, results of outcome research. Which forms of psychotherapy work best? To some extent, it depends on the mental health problem being treated. For depression, cognitive behavioral and psychodynamic therapy seems to be good. For anxiety, we have cognitive behavioral, psychodynamic, and exposure therapy. For phobias, exposure therapy and behavioral conditioning. And for issues like bedwetting, behavioral conditioning seems to be most effective. Using outcome research in therapy. Evidence-based practice refers to use of outcome research about the effectiveness of different techniques to select therapeutic interventions. Clinical decisions are made based on more than just outcome research. This is how the decisions are made. The patient's values, characteristics, preferences, and circumstances, clinical expertise, and best available research evidence. Evaluating alternative therapies. When new cures emerge, they are often promoted with testimonials. The problem: we don't know if those cures were really caused by the intervention. In addition, we don't know how many people received no benefit from the intervention. The solution? Controlled studies with random assignment to non-intervention conditions. Research and experimentation. The challenge: making sure the interventions are performed by people trained in that area. Eye movement desensitization and reprocessing, EMDR. In EMDR therapy, the therapist attempts to unlock and reprocess previous frozen traumatic memories. The therapist waves a finger or light in front of the eye of the client in order to integrate past and present in left and right hemispheres. Some studies show EMDR is effective and some do not. Studies which do not show effectiveness were critiqued by the founder as being done without adequate training in EMDR. Is this a valid critique of the research? It can be. Research suggests that the effectiveness of EMDR, even when it does work, may not depend on the eye movement technique, but something else. Light exposure therapy. Research supports the idea that daily exposure to bright light, especially with a blue tint, is effective in treating the depressive symptoms of seasonal affective disorder. What do effective psychotherapy styles seem to have in common? Hope. Therapists assume the client has resources that can be used for recovery and that improvement is possible. A new perspective. New interpretations and narratives from a victim to survivor can improve mood and motivate change. The relationship of empathy, trust, and caring provide an environment for healthy growth. Culture and values in psychotherapy. Therapists differ from clients in beliefs, values, cultural background, conversational style, and personality. Ways to serve diverse clients. Therapists should be receptive, respectful, curious, and seek understanding rather than assuming it. The therapist and the client do not have to have similar backgrounds for effective therapy. In a good therapeutic relationship, it is more important to have similar ideas about the function and style of therapy. Selecting a psychotherapist. How do you choose a psychotherapist? Specific training and experience in the area of your difficulty may be more important than the general type of license. What is most important is whether you and the therapist are able to establish an alliance. Some of this is trial and error. If problems arise, you can try working it out, but switching therapists is okay. Therapists and their varied training. Psychotherapists are not psychologists. Psychologists are PhDs and PsyDs, do therapy plus intelligence and personality testing. Psychiatrists are medical doctors with specialized training and prescribe medicine and sometimes do psychotherapy. Social workers, particularly MSWs, Masters of Social Work, as well as counselors, nurses, and other professionals may be trained and licensed to diagnose and treat mental health disorders. Better living through chemistry and other brain interventions. Some of the drugs: psychopharmacology, antipsychotic, antidepressant, anti-anxiety, mood stabilizers, how some medications work at the synapse, ECT or electroconvulsive therapy, magnetic stimulation, deep brain stimulation, psychosurgery, therapeutic lifestyle change. There are many ways and drugs that can be employed to try to aid people in dealing with their mental disorders. Biomedical therapies, interventions in the brain and body, can affect mood and behavior. They refer to physically changing the brain's functioning by altering its chemistry with medications or affecting its circuitry with electrical or magnetic impulses or surgery. Psychopharmacology refers to the study of drug effects on behavior, mood, and the mind. What do they do? Antipsychotic, anti-anxiety, antidepressants. Well, antipsychotic. They reduce symptoms of schizophrenia, especially hallucinations. Anti-anxiety temporarily reduces worry, thinking, and physical agitation. And antidepressant improves mood and control over depressing and anxious thoughts. How do they work? The antipsychotic, blocking dopamine receptors. For the anti-anxiety, slowing nervous system activity in the body and brain. And for antidepressants, increasing levels of serotonin, sometimes norepinephrine, at the synapse, possible neurogenesis. And then the side effects. Side effects of antipsychotic: obesity, diabetes, and movement problems. For anti-anxiety, slowed thinking, reduced learning, dependence and withdrawal. Antidepressant: dry mouth, constipation, and reduced sexual desire and or response. And obviously, side effects can be a major thing to consider when taking certain medications. Oftentimes, it's going to be severe side effects that will sort of entice people to stop taking their medicines, particularly if they feel like they're much better than they have been in the past, and then they're starting to be concerned about the side effects. Inhibiting reuptake. As we've talked about several times already in this course, many medications increase synaptic neurotransmitter levels. They stop the sending neuron from taking back its chemical messages before they are received. So they block the reuptake. And that's what Prozac, Paxil, those types of SSRI drugs do. They block the normal reuptake of the neurotransmitter serotonin. Excess serotonin in the synapse enhances its mood lifting effect. So, types of medications continued. Mood stabilizers and ADHD stimulants. What do they do? A mood stabilizer reduces the highs and mania as well as reduce the depressive lows. How do they work? Well, we're still trying to figure that out under investigation. The side effects: various. We have blood levels must be monitored seriously. ADHD stimulants, they help control impulses and reduce distractibility and the need for stimulation, including fidgeting. How do they work? Increase the levels or effects of dopamine in the synapses. And what are the side effects? Decreased appetite. Now, let's look at ECT, or electroconvulsive therapy. Electroconvulsive therapy, ECT, induces a mild seizure that disrupts severe depression for some people. This might allow neural rewiring and might boost neurogenesis. Repetitive transcranial magnetic stimulation, RTMS. Another option is repeated deep brain stimulation using implanted electrodes. But like ECT, these techniques may disrupt dispersive electrochemical brain patterns. Obviously, these would be situations of last resort, in that they'll take the chances of using medications to try to handle the situation for a particular client. But if the depression continues to worsen or does not get better and is really severe, they may use ECT or RTMS. Then there's psychosurgery. A lobotomy destroys the connections between the frontal lobes and the rest of the brain. This decreases depression but also destroys initiative, judgment, and control. Microsurgery might work by disrupting problematic neural networks involved with aggression or obsessive compulsive disorder. Therapeutic lifestyle change. We can indirectly affect the biological components of mental health problems. Exercise can boost serotonin levels and reduce stress. Changing negative thoughts can improve mood and even rewire the brain. Mental health problems can also be reduced by meeting our basic needs for sleep, nutrition, light, meaningful activity, and social connection. But of course, preventing psychological disorders is a major thrust as well. Preventing these disorders. Some people show a trait for resilience. They survive stress without developing mental health disorders. Some traumatized people have post-traumatic growth, finding strength and a greater appreciation for life. Community psychologists and social workers work to reduce the risk of mental health disorders by building healthier environments with interventions such as support groups for stressed families, community programs to provide healthy activities and hope for children, relationship building communication skills training, and working to reduce poverty and discrimination.